Hello, everyone. Thank you for joining us today. I'm Karen Blum. I am the Health Beat Leader for Health Information Technology for AHCJ. And today's webinar is one of a series of topic-specific training opportunities to brief health journalists on the latest information in a particular health area and to give you story ideas and resources that you can use in your work. Today's topic is Telehealth on the Line. What could happen this spring? Last December, there was a proposed continuing resolution in Congress that would have extended coverage of various telehealth services for Medicare beneficiaries for anywhere from 2 to 5 years. However, what actually passed was a much more slimmed down, short term continuing resolution, which extended telehealth flexibilities just until March 31st of this year, which, as you know, is coming up shortly. So today I'm very pleased to welcome Kyle Zebley, who is the Senior Vice President of Public Policy for the American Telemedicine Association. Kyle also is Executive Director of ATA Action, which is an affiliated advocacy group. So today, Kyle will give us a brief slide presentation to let us know what's happening, what's covered, what's not, what we might expect to see this spring, and then we'll open up to some questions. This is just a reminder to please put your questions in the Q&A box and not the chat, so we'll make sure to see those. And Kyle, we will turn the floor over to you.
Wonderful. Thank you so much, Karen, and I appreciate AHCJ for having me be able to present to you all. And definitely want to make this conversational, want to hear questions from you. And Karen, I know we'll have a little bit of a dialogue after a few slides. But again, it's a real honor to be here. And I appreciate the great work journalists do in highlighting the issues important to our community and educating the public as to where things stand. I do have a few slides that I'll walk through, again, with the central theme being that telehealth's on the line and trying to think through what is going to be coming down the pike this spring. Ideally, hopefully, action being taken before the end of the month, as Karen mentioned. Real quick, before I do that, I thought it would just be very helpful for you all to have some context about who the American Telemedicine Association is, for those that might not be familiar with us. We've been around for 32 years this year, founded back in 1993. We're an association of over 400 organizations, and that's really the width and breadth of the healthcare system. So we represent hospital systems, we represent commercial payers, academic medical centers, virtual-only providers, medical device manufacturers, pharmaceutical device manufacturers, health law firms, healthcare advisory firms, even government agencies on the ATA side, like the Department of Defense for TRICARE and the Veterans Administration as well. It's my great joy leading public policy for the ATA to really build policy recommendations for federal and state policy makers as to the way that the healthcare system in the United States can deliver virtual care options for every American. Every one of the areas in which we engage in fall under one of these 9 policy principles on our slide. And at its core, what it's about is making sure that telehealth becomes an integrated part of the U.S. healthcare system, not something separate and apart, and that we're using all the technology that we can in the 21st century to make sure that people are living happier, healthier, longer lives, ideally from the comfort of their own home or wherever they might live through the use of healthcare technology. Like I said, I handle both federal policy and state policy. I come from a federal policy background. Prior to joining ATA in the summer of 2020, I spent about a decade in government, including 6 years up on Capitol Hill and almost 4 years working at the U.S. Department of Health and Human Services. And so I have a great background in federal policy and have a good sense, I think, of how Congress and the federal government works, or how I sometimes say it doesn't work. And we were able to make extraordinary gains early in the pandemic, about half a decade ago, for telehealth. So even though ATA was founded in 1993, even though there had been leaps and bounds improvements in what technology could do in delivering care remotely via technology to break down geographic barriers, By the time the beginning of this decade, the beginning of 2020 rolled around, we had actually made very little gains as a community in terms of federal policy. Indeed, by the beginning of 2020, the biggest area of the that the federal government can use to deliver care to the American people in a holistic way, where the federal government's the main driver of policy, is Medicare Part B. And Medicare fee-for-service had very little telehealth coverage available to the average beneficiary at the dawn of this decade. And that was because of a 1997 law, which was seen as very progressive at the time, at the very beginning of the second Clinton term in office, that by 2020 was very outdated, to be honest with you. And that was considered the Section 1834M of the Social Security Act. And what that meant at that time in 1997, when it became law, was you would have access to telehealth and virtual care services if you met two criteria. One, you had to be in a rural area outside of a major metropolitan area. And two, you had to be within the four walls of a Medicare provider's office. You had to be in a brick and mortar Medicare provider's location. It's head spinning. And it was head spinning to the telehealth community at the beginning of the decade that we had this 23-year-old chain around the community, and less than 1% of Medicare beneficiaries having access to telehealth services. And even those few Americans that were Medicare beneficiaries that had that access, you had to be in a brick and mortar location outside of your home in order to receive reimbursable telehealth coverage. What the Trump administration in its first term did in response to the COVID-19 pandemic was put in a number of various federal policies designed to be temporary, to keep people in their home when possible, out of healthcare settings when possible, to stop the spread of the COVID-19 pandemic. So these were all really attached to the COVID-19 public health emergency. And on our screen here, on this slide, on the left are a variety of flexibilities they put in place. And most of these were kept in place well after the pandemic. And the latest action that Congress took significantly lessened the number of policies that were extended. And we only got extension for those that we won until the end of this month. And I'll talk you through that in just a moment here. So the biggest tool, again, were the Medicare telehealth flexibilities. And the biggest area of those Medicare telehealth flexibilities that were loosened by President Trump's action at the beginning of the pandemic and kept in place ever since. So we're now at about half a decade, 5 years of these flexibilities being in place in Medicare, was waiving those geographic and originating site restrictions that I mentioned. So that now means that for 5 years, every Medicare Part B fee-for-service beneficiary has access to reimbursable telehealth coverage, regardless of their geographic location. So you go from under 1% of Medicare beneficiaries having access prior to the pandemic to 100% of Medicare beneficiaries having access since the pandemic. It's all been done on a temporary basis. We've never had it done permanently. That's despite the fact that it was put in place on a bipartisan basis by President Trump, kept in place on a bipartisan basis by President Biden and Vice President Harris. And now we're in a situation where we're back to Trump 2.0 in his second term. And he was able to have these flexibilities put in place. And we're hopeful that President Trump will be able to continue them and ideally make them permanent before too long. So those are the Medicare flexibilities. That includes a variety of other areas of coverage, but most notably, it's this idea that every Medicare beneficiary has access to telehealth services. There's a really innovative program started during the pandemic called Acute Hospital Care at Home. And this frees up hospital beds for participating hospitals, allows for convalescing patients in acute care settings to be discharged from the hospital in a physical brick and mortar setting and go home. And through the use of remote monitoring technology, synchronous audio-visual telehealth care, and other areas that are done in a hybrid way, including attending nurses and physicians as necessary, we can free up hospital beds and get folks back home to convalesce in the comfort of their own home through the use of technology and hybrid care. It's a really innovative, forward-leaning program, and that's been extended until the end of this month as well. And it seems pretty well paired with the other Medicare telehealth flexibilities, which is great from our perspective because we want to make this permanent in the long run. Other provisions that I'm just going to march through real quick on the left are, again, all these pandemic era flexibilities that were inducements to use telehealth. So there's what we call first dollar coverage of high deductible health plans, health savings accounts. What this meant was before you hit the deductible, if you were one of the tens of millions of Americans that have high deductible health plans in the commercial market, and you have health savings accounts attached to it, you didn't have to reach into your own pocket before coverage kicked in for you through your HDHP, HSA accounts. Bottom line was, this was an inducement to use all the various wonderful things that telehealth does in terms of preventative care or mental health care or much else besides, that made it much cheaper and easier for the tens of millions of Americans on HDHPs to have access to telehealth services. That was a provision that was more or less in place until the end of last year. In the original version of that omnibus bill that ended up getting derailed, this would have been extended for 2 years. Instead of getting extended, it was been allowed to lapse. We're trying to bring it back to life. Another thing that happened during the pandemic was the Medicare Diabetes Prevention Program had been expanded temporarily to include a variety of telehealth and virtual care components. That was allowed to lapse in 2023 with the end of the COVID-19 public health emergency, and it hasn't been brought back. That original omnibus bill that ended up being derailed, that included all these wonderful provisions that extended things for 2 or 5 years. This would have been extended for 5 years, which would have been a great win for the telehealth community. Unfortunately, that's lapsed, and we want to bring that back to life. So too is this concept of in-home cardiopulmonary services. That wasn't something that had been offered prior to the pandemic. It was offered during the pandemic. It's been allowed to lapse. And then there's a really important concept I'm not going to spend too much time on, but there has been a waiver that has been in place starting with the first Trump administration in conjunction with the COVID-19 public health emergency that allowed for remote prescribing, telemedicine prescribing of clinically appropriate controlled substances, certain Schedule 2 through Schedule 5 controlled substances, so that you didn't have to have an in-person visit first in order to maintain a provider-patient prescribing relationship. The DEA is on the hook to get this right. We're hoping that Congress will continue to provide oversight, and there are draft rules right now circulating for public comment, and we're hopeful that the DEA is going to get this right without going backwards to this half-decade worth of access that we've achieved. Where are we now? Like I said, there was this omnibus package, 1,500 pages long, that was carefully drafted by House Republican and Democratic leadership in coordination with Republican and Democratic senators in leadership. And they unveiled this package that would have kept the government funded through March 14th of 2025 of this year. It was unveiled in the middle of 2025, in the middle of December 2024. One of these classic backroom packages that emerges sometimes in the dead of night with a deadline fast looming, with Christmas break looming, with the idea that it was a lame duck Congress and people, including defeated members or retiring members, wanting to go home. So the leadership thinks, it's very hard to get things across the finish line in both houses to the president's desk. So we'll jam everybody and we'll get all of our must-do work done by putting every provision that could expire or that has a powerful and influential constituency into these moving packages, these moving vehicles, as we call them, inside DC. And it was a great victory for us, just shy of popping champagne corks. We were going to get 2 years extension for Medicare telehealth flexibilities. We're going to get 2 years extension for this HDHP tax provision, 5 years for the expanded diabetes prevention program and acute hospital care at home. And so it was going to be a series of major wins for us. President-elect Trump really, I think, being spurred on by Elon Musk, ended up weighing in on social media that this was too much to be included in a short-term funding package. Too many policies, too much add-ons to their comfort level. And they wanted to have a chance to make an imprint on all these policies. And I think, frankly, they probably didn't want to give President Biden a bunch of wins. So even though this was all done and negotiated on a bipartisan basis, those interventions on social media by President Trump and by Elon Musk killed that bill in its tracks. And everybody went scrambling. And we knew that over the course of just a day or two, I think the bill was unveiled on a Monday in mid-December. On Tuesday, I was riding high and excited that we were going to get a huge number of wins done for our community. On Wednesday morning, Elon Musk said he was concerned about it. And I was worried if President Trump weighed in, it would be over. Wednesday afternoon, President Trump weighed in and killed it. Thursday, everybody scrambled to make sure that we got included in a slimmed down package. We were included. And after a few more trials and tribulations, finally Friday evening, a 3-month extension for Medicare telehealth flexibilities, 3-month extension for acute hospital care at home till the end of this month of 2025 were included. And everything else, practically speaking, was left out. Our priorities and many other powerful, influential constituencies were left out. And that's what ended up becoming law. Right now, we have 3 pathways towards extending these flexibilities that were included past the end of March, and I'm very confident that's going to happen, and I'll tell you why in just a moment. And then we're also fighting for a way forward on all those items left out. I think we're most likely, as of 12:15 p.m. the afternoon of March 7th when we're talking, we're most likely going to be included in a soon-to-be unveiled continuing resolution. And it's looking like we're going to get another extension for Medicare telehealth flexibilities, another extension of acute hospital care at home till the end of September, at the end of this 2025 federal fiscal year. So that'll give us another opportunity to fight another day. We don't believe we're going to find a home, not because we haven't put a lot of effort behind it, but we don't believe we're going to be able to find an immediate short-term home to bringing back to life the HDHP provision or the expanded Medicare diabetes prevention program or in-home cardiopulmonary services. There are other vehicles that could move, including a standalone health package, which would kind of stitch together everything in that original version of the omnibus bill at the end of last year. And there's a real desire amongst many congressional leaders to bring all those provisions back to life. Hopefully we can be included in that. But that's probably the most likely step forward. Republicans, understanding these are bipartisan issues, and we do have broad-based support across both parties, across both chambers, across ideological lines. And we could talk about that more if Karen wanted, as to why we're in that rarefied position of healthcare policies that are very popular. Despite all that, we would almost certainly not be included in a reconciliation package. And we wouldn't be included in this Republican-led reconciliation package because of our bipartisan support. They don't need to put us there. They don't need to offset our costs there. That would be more of a purely partisan exercise. And they wouldn't need to spend, a few $1 billion to cover our items while they're trying to cover the $4 trillion tax cuts and having offsetting, reductions in Medicaid coverage and that kind of thing that I'm sure many of you are following very well. So that's where we stand now. And happy to talk again about maybe why we're so popular and bipartisan, or why we're in a situation where a popular bipartisan issue that isn't permanent yet, and perhaps can share some of my reflections as to the comparative dysfunction of Congress as to the way it was intended to work, which is everybody's fault and nobody's fault from my perspective. But want to turn it back over to Karen and enter into a conversation with you, and obviously eager to answer any questions that folks from the audience might have. So thanks again, Karen. And I'm going to stop
Yeah.
sharing my screen.
All right. Kyle, thank you so much for explaining all this with your lots of, we talked, you had what, 10 plus years so far in Washington with all the inner workings. I really appreciate that insight. So I have just a couple of questions for you, and then if people on the call would like to ask questions, please go ahead and put those in the QA and we will address those. So one of my questions for you is, last month there was a rumor started, I'm not sure how, that Medicare would stop covering telehealth services starting April 1st. Can we talk about that a little bit? How did that come about? How did your organization respond?
Yeah, happy to. And this is an area where there's about to be or already has been published, for instance, one of those political fact checking exercises. So uh, on the 21st, I think it was of February, I woke up, had a busy Friday, 2 Fridays ago, lots of calls, like this. And I kept on getting inundated with text messages, emails, social media statements from folks on LinkedIn, panicking because the night before on Thursday, Congressman Ro Khanna of California, progressive Democrat, had put out some messaging saying that the Trump administration's announced that Medicare telehealth coverage ends April 1. Don't let President Trump do this. He's going to take away Medicare telehealth coverage. And I was worried about it, but it just seemed so far afield from my understanding, our conversations with the White House, President Trump's prior support of telehealth, the fact that RFK Jr. during his confirmation process as to be HHS secretary had been on the record in support of telehealth, the Make America Healthy Again commission that was put in place by executive order by President Trump included an accompanying fact sheet that had telehealth as one of the great achievements of the first Trump administration regarding healthcare access. It just seems very much, what does Congressman Khanna know that we don't? And I think it's a matter of interpretation and context that was missing. And Ro Khanna getting involved in this is not a bad thing at all. It really clearly raised this concept in the public consciousness that Medicare flexibilities were at risk,
Mhm.
and that's a good thing. But what we're concerned about always is that our very bipartisan, popular set of issues, popular with presidents of both parties and members of Congress of both parties, would suddenly get sucked into this partisan, polarized, divisive moment. And we would be seen as part of a kind of a political football in a way that we hadn't been to date. So what we thought was missing in some of the reporting and some of the concerns raised from those that were paying attention on social media was context. Yes, the Centers for Medicare and Medicaid Services put out a very simple, straightforward statement on the website saying April 1 was going to be the end of Medicare telehealth flexibilities. They did that because they've done it before, including under the Biden administration, and they do that because that's what Congress has told them is going to happen. Until Congress proactively acts again, such as including an extension of these flexibilities in the next continuing resolution package, Congress has told them, stroke of midnight, March 31st, telehealth flexibilities end.
Mhm.
I don't think that's going to happen, but the CMS and the great men and women, career professionals at CMS have to assume that Congress has told them the truth and that it
Mhm.
won't be extended forever, even though we know in reality it has been extended in the past and is almost certainly going to be extended again. And so it wasn't President Trump, through a statement on the CMS website saying that
Mhm.
he's opposed to telehealth services. I think instead it was, men and women, civil servants, professionals, non-political folks that stated what is
Mhm.
true, that these flexibilities will conclude, barring congressional action. So we
Yeah.
put out a statement just saying, no need to panic, don't run for the exits. Healthcare systems, individual Medicare providers, patients relying on these services across the country. Um, yes, this is how Congress operates. Yes, it's no way to run a healthcare system, but these still continue to be bipartisan issues. We
Mhm.
expect that bipartisan support to continue. And we think Congress will pass and President Trump will sign into law another extension of these flexibilities.
Yeah. My other question for you, you mentioned that the most likely scenario you see happening right now is there will be another short-term extension just till September. Why are there so many like short terms, 2 years here or 6 months here? Would they ever be made permanent?
Anybody that has covered or participated or worked in and around the U.S. healthcare system for any extended period of time and follows public policy will tell you, unfortunately, this is par for the course.
Okay.
And it's not just telehealth that's in this endless merry-go-round of short-term extensions. And I was really kind of referencing this fact a few different times in my PowerPoint presentation during my conversations there. But it's how Congress and the federal government now operates.
Mhm.
Very rarely do they pass permanent bills into law. What instead they end up doing is they pass a very slight number of bills. Usually they're absolute must-do bills, like keeping the government funded, like raising the debt ceiling, like making sure that agricultural programs are funded, or the Department of Defense is appropriately authorized. And they don't do this through the normal committee process anymore. So, there was that old cartoon how a bill becomes law, and
Yeah.
you start as an individual initiative from a member of Congress, and it works its way through committee, and it gets amended, and other people weigh in, and the House might pass a version of a bill on this topic. The Senate might pass a version of a bill on a similar topic, having worked their way through the processes in both chambers. And then through a conference committee of Republicans and senators, they work out the details and they go back and pass this new version, and that is the one that gets down to the president's desk. And this might take a few months, or even a year and a half in some circumstances to work its way through. No, it doesn't happen that way. Instead, what happens is in what used to be smoke-filled rooms, uh, leadership offices, usually the Speaker or Minority Leader's office in the House and the Majority Minority Leaders in the Senate, they, along with young staffers, stitch together bills that include all types of riders of things that are about to expire, bad things that will happen if Congress doesn't act. They'll attach that to a must-pass bill, so-called, and they'll give their caucuses in both the House and the Senate 72 or 96 hours to take it or leave it. Do you want the government to shut down? Do you want to have a debt ceiling crisis? Well, if you don't and you want to go home and you don't want to stay up through endless nights of bickering, just pass this bill.
Hmm.
That happens under both parties in the majorities of both houses. It happens when there's unified majority in both houses. It happens when Republicans and or Democrats are in the White House. And I think it's just in a degree of and symbol of our dysfunction. So if you're in healthcare, you're always, every year, usually towards the end of every year, you're sweating it out, wondering if some important set of policies that are impactful to the way you're delivering care is going to be extended again. And usually they do it until the very, wait until the very last minute, and they make you sweat it before they finally do the right thing and kick the can, because God forbid you do it permanently. You kick the can because of the cost involved with doing something permanent sometimes, or other factors. I mentioned I do also handle state policy, track all 50 states. We've made state laws almost uniformly better on a permanent basis for telehealth, seizing this really positive moment coming out of the pandemic. And it's a marked contrast to the federal government. Whether or not these are Republican states or Democratic states or purple states, they actually do all the things that you would expect a legislature to do: work in regular order, work through committee, mark up legislation through various amendments being offered, work out the differences between the two chambers, and get a whole set of packaged laws to a governor's desk every year, year in, year out, that these state legislatures are in session. That's how, ideally speaking, the federal government should work, and it doesn't. And again, it's in marked contrast and why we find ourselves in this position.
Yeah, interesting. Okay, there are a couple of questions that came in through the Q&A. I know you have to sign off in what, 15 minutes or so, so I
Yeah.
want to make sure we get these. One person asked, is there anything that the public can do to pressure Congress to extend telehealth?
Yes, absolutely. And we actually have a tool that I can try to dig up real quick in just a moment that will make it easy for folks to weigh in. And I've got that right here. And this is a way that folks can pick up the phone, call their member of Congress. It's a very easy way to do it. And I'll show you real quick on sharing my screen. There we go. uh, this still matters. Having worked in a congressional office for 6 years, uh, emails into the office and calls into the office really matter. They're scored and tallied up by congressional staff. They're presented on a daily or a weekly basis to the member of Congress. Usually, the kind of rule of thumb is that one individual calling and emailing is at least 10 constituents that didn't take the time to do so. And so, calling your member of Congress, your House rep, your two senators, and telling them, I'm Kyle Zebley, I'm a constituent. My loved ones rely on Medicare telehealth flexibilities. Our hospital systems rely on delivering care to patients. Our Medicare providers rely on it in order to deliver care to patients. Make sure it doesn't expire at the end of this month. That'll get through, and that matters. You can do it through a tool like this that we started operationalizing a few weeks ago, or you can just do it on your own with the understanding that folks that actually take the time to contact their member of Congress do get through. They do make a difference. Also, of course, have told our member organizations uh, that they make a huge difference in their constituency and their congressional district, that they should be contacting their member of Congress in particular as to where their organization is based, and tell their member of Congress their expectations to weigh in with leadership, weigh in with the right committees, and make sure that these flexibilities don't go away. So that's the biggest way to get involved, making sure your voice is heard on congressional phone lines and in congressional email inboxes.
Okay, great. Thank you so much. Another question, is there any indication of when the potential continuing resolution is going to come out?
Today, we
Oh,
think it's going to be as soon as today that the draft will be unveiled. Might sink into the weekend. And that was their original deadline from a House Appropriations Committee Chairman Cole, Tom Cole of Oklahoma. But we think it's going to come out potentially as soon as today. And by every indication, um, but it's not there in black and white, and I don't trust anything until it's on the president's desk with a signature on it. But every indication is that telehealth flexibilities, acute hospital care at home will be included, and that the timeline for that will be in the end of September. And what's going to be a wonderful indication for our community, and is another positive confirmation of our support, is that there's going to be maybe 3 to 4 policy riders, as they call policy provisions included on what is more or less a very simple, straightforward extension of current government funding levels till the end of September. So a lot of constituencies lost out in that omnibus
mhm.
back and forth at the end of last year in December. And we got included even in a slimmed down package. A lot of disappointed advocates are out there on a whole host of issues. They'll be disappointed again that they were not included on this short-term continuing resolution. And it's a sign of our broad-based support that we are being baked into that. But I believe it when I'll see it. And even if we get this CR introduced, it's not the end of the line. Just because the legislative text is out there doesn't mean it becomes law, though it's a good indication. I think that that's going to end up what gets included. Our current dynamics are such that House and Senate Democrats and Democrats around the country are inflamed. They are angry. They want that frustration made clear in the halls of Congress. And the most immediate way, in a practical legislative sense, that Democrats can voice their displeasure with Elon Musk and the Department of Government Efficiency and other actions of the day that President Trump has done that will have undoubtedly upset them. The biggest way that they can express that displeasure is to shut down the government. And that could happen on the 14th. Hopefully it will not last long, but that's when government funding lapses. Importantly for us, we've got a 17-day buffer where the Medicare telehealth flexibilities are around till the stroke of midnight on the evening of March 31st. So our hope is, even if there is a shutdown, and I actually think it's more likely than not, I hope I'm wrong, but again, because of Democrats being so upset, if there is a shutdown, we have some time for them to come together, find a way to open the government, and then make sure that when they do, we're included in that continuing resolution that funds the government through the end of September.
Okay, so you piqued my curiosity when you were telling us before. So tell us why this is, even in a divided um, government, why is telehealth have the bipartisan support that you mentioned that it does?
Well, thank you so much. I think it's because of a few things. One is that telehealth has been proven not to only be a rural tool, a way to meet rural Americans where they are with all of their geographic, frankly, disadvantages and isolation from the healthcare community. And so for decades and years leading up to the pandemic, it was thought that telehealth would be a great way to expand access to those Americans. And since the beginning of the century, since the early 2000s, we've seen upwards of 20% of rural hospitals close. And there's this whole concept that folks are aware of very well, that your zip code is your healthcare destiny. But since the pandemic and the fact that every American now has had, with virtually almost no exception, some exposure to telehealth, it's now been clear that telehealth is a great tool for suburban Americans and urban Americans. I live in the heart of Washington, D.C. For me to go for in-person care in a center of the healthcare system with lots of options, you still have to take time out of your day. You still have to fight traffic or go across town. Still going to take you a couple hours. There are still a lot of very few options available to me as somebody with commercial insurance that presumably would have more access than most other Americans. And it's still difficult to find a brick and mortar in-person provider to see me, and it still takes a lot of time to go there. So it's also been proven to be an urban tool and a suburban tool in addition to being a rural tool, because what telehealth does is it's more efficient, it's effective, it's clinically appropriate, it expands the pool of healthcare providers with whom you can meet. And so every congressional district has benefited from increased access to telehealth services, regardless of whether or not it's a rural Republican area, a purple suburban area, a Democratic blue city center, regardless of whether or not it's Medicare fee-for-service, Medicare Advantage, Medicaid, so for dual eligible Americans, Veterans Administration, TRICARE, Indian Health Service, all of them have really vastly expanded their telehealth offerings, and Americans that have access to it want to maintain it. And so it's a very rare example of a bipartisan healthcare issue because it's ensured that no American would be left behind. And I think that's one of the great reasons why we have this broad-based support. Then from practical purposes, President Trump put it in place, working on a bipartisan basis with the Congress early in the pandemic. It showed itself to be something that is effective and clinically appropriate, that President Biden kept it in place. One of the very few examples of an issue that's, went into his administration that he carried on the Trump legacy, such as it is. And so now that President Trump's back, we never hesitate to remind anyone that's listening that it's really valued, an important part of his legacy from his first administration that we hope that he builds upon and makes permanent now in his second term.
All right, great. Thanks. I know we have just a couple minutes left till you need to go. Is there a final sort of take-home message that you'd like to leave us with today?
Well, I think that one of the most important things at the federal level is to go ahead and get us into a place where we can make permanent these really sensible, popular provisions put in place early in the pandemic. Like I just noted, this is a great opportunity for President Trump to do something meaningful and lasting that would complete the circle of what he put in place half a decade ago. And having done that, there's a whole host of other things that the telehealth community can then begin to weigh in on to improve our healthcare system in terms of the appropriate deployment of AI in healthcare, in terms of updating our health data privacy laws, in terms of breaking down interstate barriers to care, in terms of really making sure that the healthcare system's nimble and flexible enough to deploy clinically appropriate remote monitoring devices, connected health devices, to again make sure that individuals are receiving bespoke, individualized care where and when they need it, and that at the end of the day, we're going to deploy 21st century technology to make sure that people live happier, healthier, longer lives. And I think it's a vision that is a positive one. I think in this really divided time, it's one that unites Americans, and there are very few issues that do. And so we just need to seize the moment and break through the dysfunction to make it happen. And I'm positive and optimistic that we will. And it's just going to be a lot of trials and tribulations leading up to that.
Mm, great. Well, thank you so much for sharing your time with us. And thank you to everyone in the audience for tuning in. I know, just like Kyle, there are a lot of demands on everyone's time and a lot of news fighting for our attention these days. So I appreciate everyone fitting this in. If you joined us late, you will find the recording of this webinar online at healthjournalism.org in just a few hours. And AHCJ will continue to bring you webinars on a variety of health topics as a perk of your membership, including a program next week that will be moderated by our colleague Anna Medeiros on finding new journalism outlets in a time of a lot of layoffs. So we're looking forward to that too. So I hope everyone has a great rest of the day, a good weekend, and good luck on your stories. Thank you.